Good afternoon. I'm Nicolas Girard. I'm a thoracic oncologist at Institut Curie in Paris. And welcome to this e-cancer discussion. This will be a roundtable focusing on real-world data and diagnostics in patients with non-small cell lung cancer with EGFR exon 20 insertions. For this discussion, I will have a pleasure to have several experts in the field, Dr. Passaro, Dr. Kerr, and Dr. Griesinger. Maybe you can present yourselves.
Hi to everybody. It's a great pleasure for me to be here today. So I'm Antonio Passaro. I'm a medical oncologist in the Division of Thoracic Oncology in Milan.
My name is Frank Griesinger. I'm a hematologist, oncologist at the University of Oldenburg, Pius Hospital, and I'm treating a lot of lung cancer patients, and we're doing quite a bit of molecular testing and also molecular studies.
My name is Keith Kerr. I'm a pathologist with an interest in lung cancer, working in Aberdeen in the UK.
So today we want to discuss, based on the abstracts presented at the ELCC 2021 meeting, some of the key aspects in the epidemiology, the diagnostics, and the treatment of patients with EGFR exon 20 insertions. First, maybe discussing those mutations and the differentiation of these mutations from the common EGFR mutations. Maybe Frank, you want to discuss the incidence and the heterogeneity of those exon 20 insertions?
Thank you. So exon 20 insertions is one of the uncommon mutations. I think we all know the distribution that was proposed by Young, and this is kind of the group 3 uncommon mutations. There's the group 1, which can be treated most likely with first, second, and also third generation TKIs. Group 2 is normally a common mutation in combination with the T790M, sometimes also just the de novo T790M, which is pretty rare. And then the exon 20 insertions, which is group 3. And these are about 6 to 8% of the EGFR mutations. We've actually looked in CRISP in this large cohort, and it's exactly 6.7% of all the EGFR mutated patients. There is a difference, and maybe Keith can dwell on that a little bit more, exactly where the mutations are. And this is also reflected in one of the abstracts. So the most common ones are the insertions in the domain, the TKI domain, in the tyrosine kinase domain, and not in the helix. And there seem to be some differences with respect to the response to EGFR TKIs. There's also one aspect that came out at the WCLC, showing that if one tests just with normal kits for EGFR mutations, let's say like COBAS and other kits, one obviously loses up to 50% of the EGFR exon 20 insertions. We have now some targeted therapies. Everybody heard about prosiotinib and mobocertinib, and there's now also a study with amivantamab up and running. So these patients should be tested. They should be identified. They should be identified with sensitive methods, and then also treated according to the availability of new drugs.
Okay, Keith, maybe you want to discuss further the need for NGS to identify those mutations, because there are many of these, and then some complexity in identifying those mutations, and this is what was reported in one of the abstracts presented during the meeting.
Sure, thanks, Nicholas. And just to echo what Frank said, the exon 20 insertion mutation family probably is the third commonest group of EGFR mutations after the common exon 19 deletions and then the L858R point mutations. So as a group overall, they account potentially for quite a significant number of patients. I think that the very wide range of numbers that are reported in the literature, anywhere from 1% of EGFR mutations up to some big studies have reported even 12% of EGFR mutations are of this type, is at least in part relating to the technology that's used. So again, as has been alluded to by yourselves, to some extent, it's a matter of you find what you look for. And if you are using allele-specific single gene assays based on PCR, you will only find the mutations that the test is designed to find. And this has actually been a phenomenon that has caused problems with the reported mutation prevalences right from the start in the EGFR mutation story, and indeed in some of the other mutations. So with an approach, however, like next generation sequencing, or even Sanger sequencing, although virtually nobody is probably using Sanger sequencing these days in earnest in a clinical sense, you will find mutations in the exons that you look at. So you will find all of the mutations. So as we become interested in exon 20 insertion mutations, it's really important to have a methodology that is going to find them. And for all practical purposes now, next generation sequencing is the go-to methodology for that. We don't properly understand whether there are differences, say in different countries with different ethnicities around exon 20 insertions, but from the data that have been reported from North America, now from Europe, from the ELCC study, and also from the Far East, there's no obvious evidence that there is a marked difference in exon 20 insertions per se. They seem to be fall into the same category as all the others.
Antonio, what are the clinical characteristics of those patients with exon 20 insertions? Are these patients different from patients with common EGFR mutations? Do we have any clinical features that may be associated with exon 20?
So in the data that was reported in the ELCC by Christopoulos in the real world data, so the clinical feature was similar to the other exon mutation, exon 19, exon 21. So we have a prevalence of females, a never smoker, light smoker. So we have a differentiation from the single alteration of the tyrosine kinase inhibitors, but maybe we have the same background, biological background for this kind of disease. And this is very important to confirm the need to test all our patients regardless of the first positivity or not on the exon 19, exon 21. So as discussed before by Frank Griesinger, it's important. We have a 3 big block of patients with EGFR mutation. So common, sensitive, uncommon, and the exon 21 insertion. That's a very different entity today. So from my clinical point of view, moving from the diagnostic point of view of the Keith Kerr, is important to understand that at the present time, I think that the clinical is very, very slow compared to diagnostic. So, for example, in Italy, I think that only 25–30% of non-academic centers are able to test our patient with the NGS analysis. And so this is a dramatic if we understand that they have a therapeutic target, We have a diagnostic ready to identify this patient. We have a clinical feature to understand maybe this kind of patient that we have not the methods. Please, Frank.
Yeah, I wanted to back that up from Germany in terms of NGS, and in CRISP, in this registry, we do have basically specialized lung cancer centers, hospitals, comprehensive cancer centers, and also practices in town, because we have a specialty in Germany that also in oncologists that are practicing in town, they are also treating patients with non-small cell lung cancer. And we have a rate of now 45%. We started with 30% of patients that are tested with NGS, and we're up now for 45%. We know that in Austria, they are close to 100%. In Switzerland, I think they're at 90%. We have in our guidelines, it's stipulated, please do NGS, but there are still hurdles to really do this in the broad spectrum. And I'm not talking about small hospitals or not specialized hospitals. The rate is probably even lower.
Still, this testing, this NGS testing, has also maybe to be viewed in the general context of molecular characterization of non-small cell lung cancer. We have more and more alterations to look at, because we have drugs even for very rare alterations, and I'm thinking about KRAS G12C, but still highly somehow frequent, but we have also the RBB2 mutations, we have the RET fusions, and so on and so on. So I guess the availability of new treatment dedicated to exon 20 will actually push everyone to do a systematic NGS. But even in France, where we have those academic platforms and so on, maybe less than 50% of patients actually are tested in the frontline setting because of financing issues and so on. And I agree with the kind of differences between small centers and larger centers. Still, this molecular characterization may have some impact when we classify the exon 20 insertions between the near loop and the far loop with regard to the efficacy of available agents, including mobocertinib, poziotinib, or amivantamab. But maybe before discussing those new treatments, Antonio, maybe you want to comment about this abstract, looking at the standard treatment for those patients, and especially reporting on the efficacy of immune checkpoint inhibitors, which are standard of care in non-small cell lung cancer overall and without such alteration.
Yeah, so this is a very key point. In this particular setting, we have that chemotherapy performed in the same time of 15 years old, so we have a globally overall survival at less 24 months. And this particularly subgroup of molecular alteration, exon 20 insertion, we have that the failure immune checkpoint inhibitor. So we have a particular target without any very active agents. And this is important to understand and to confirm when we have new data that are coming up. So, and also to understand how to improve the sequence of this kind of patient clinical practice. If we have that those patients are not responding to the immunotherapy, and we have the availability of clinical trial after, we have to improve the enrollment of patients with exon 20 insertion in clinical trial if we have no new drugs in the clinics. In the other hand, it's very important to confirm and to stress that this kind of patient should be not treated with the standard tyrosine kinase inhibitors. First, second, third generation tyrosine kinase inhibitors are not effective in this kind of subpopulation. So we have a very small data that confirm a limited improved activity in favor of osinertinib with a double dose, but was based on a very, very small phase 2 and very, very small overall patient population. So it's important to confirm that the chemo, in absence of any clinical trial or any specific data, is the standard of care for patients with exon 20 insertion. And from the abstract of Christopoulos and the colleagues, it's not clear if the combination chemotherapy plus immune checkpoint inhibitor is able or not to improve the standard effective of the chemotherapy alone. So data are based on a very, very small group of patients. But considering the hypothetical sequence of a chemo followed by a tyrosine kinase inhibitors direct from exon 20 insertion or by antibody, for example, as amivantamab, I think that we should prefer the chemotherapy alone instead of a chemo plus immunotherapy. But this is only in my opinion.
No, I agree with you. We have some reports in the literature about the limited efficacy of immune checkpoint inhibitors in this population. These patients are still EGFR mutant non-small cell lung cancer patients, so probably with limited tumor mutation burden, with an immunosuppressive microenvironment, and with the limited amount of neoantigen overall. So to me, the rationale to use immune checkpoint inhibitors in those patients remains limited. And from the abstract presented during the meeting, we see that immune checkpoint inhibitors alone are associated with very low response rate. I know that this is a very limited subset of patients, but this seems to confirm that immune checkpoint inhibitors should not be used in those patients. And there were also some reports of hyper-progressive disease in the literature. So I agree with you that chemotherapy alone is probably the standard of care. Frank, what do you think?
Well, I mean, we also have in the common mutations the IMpower 150 data. So at least there, it seems that immune checkpoint inhibitors have some effect. I agree completely that a single agent immune checkpoint inhibitor probably should not be used. But as far as I know, the studies that are ongoing also have as a control arm either chemo or chemo plus immune checkpoint inhibitor. So I think the call is out. We don't know yet. We have to probably have to see in registries or also then in the trials how these patients fare with the combination. But just to make this point clear, immune checkpoint inhibitors as single agent probably does not work.
So new treatments, new options for those patients, TKIs, so poziotinib, mobocertinib, and one antibody, amivantamab, targeting MET and EGFR. Antonio, maybe you want to discuss poziotinib, mobocertinib data. This data presented at the last ASCO WCLC meeting and reporting on actually some very interesting response rate.
Yes, so this kind of tyrosine kinase inhibitors moved from the data that we have in the standard common EGFR mutation, and during the past and during the development, they was limited exclusively, in my opinion, for the toxicity profile. Both the new drugs, the tyrosine kinase inhibitor, the poziotinib and mobocertinib, showed a very interesting data about the overall response rate, surely been over that chemotherapy. But the border drugs were limited for the toxicity profile. In particular, poziotinib have a very difficult development with a very different step of different reduction dose for patients that are receiving the clinical trial. And I think that for poziotinib, the very limiting factor for the clinical practice should be the toxicity. In the other hand, mobocertinib maybe, in my opinion, is the best tyrosine kinase inhibitors compared to the other drugs, and have a very, very interesting activity for this kind of patient. But I'm not sure that comparing and balancing very well efficacy and toxicity, there will be a room for mobile setting in clinical practice. So the data that are coming out from the evaluation of the different kind of region in which we have the exon 20 insertion maybe are the key to understand that using a tyrosine kinase inhibitors in this particular molecular subset is not the great way for our targeting, compared to the other drugs that is a monoclonal antibody.
Keith, maybe have you seen any data regarding the co-mutations associated with exon 20 insertions? Do you think that this may also impact the efficacy of any kind of targeted agent?
There are some published data with respect to co-mutations occurring with exon 20 insertions. And I think in summary, the pattern of co-mutational, pattern of co-mutations is more or less the same as is found with the common EGFR mutations. So in that sense, the picture with exon 20 insertions appears to be no different. The question, though, that you posed is, will the co-mutational picture influence outcomes? And I have a feeling that probably it will. When we think about the data that we have seen with TKI treatment of common mutations and the presence or absence of a p53 mutation, there seems to be quite compelling evidence. And this I think is a consistent biological phenomenon, because it's actually been reported with ALK, and I've seen reports also with ROS, that the coexistence of the p53 mutation makes the therapy less effective, and therefore there may be an argument in those patients of adding chemotherapy with the TKI. So why would exon 20 insertions be any different in that sense? At the moment, we know no reason why they should be.
I agree with you. Actually, those TKIs, probably we have some difficulties to interpret the results in terms of efficacy because of the heterogeneity of exon 20 insertions, because of the co-mutation. So it's not the same story as common EGFR mutations. Probably here we have more variables to integrate in a model to predict the efficacy of those drugs. The second strategy to target exon 20 insertions is amivantamab. Frank, maybe you want to discuss some of the key data with amivantamab?
Well, we saw some data at the WCLC, and actually amivantamab had the highest response rates and also the highest and longest PFS, and their mobocertinib and poziotinib were much inferior, and also the tolerability of amivantamab seemed to be much better. So GI toxicity and also skin toxicity were much less pronounced. So I think we see now a shift from TKIs to antibodies, and maybe also antibody drug conjugates, because we've seen that for HER2. I mean, this is not the topic today, but with this trastuzumab plus deruxtecan it has really fantastic response rates in HER2 mutated, not in overexpressing, but mutated patients. So one wonders whether amivantamab plus a payload might be even more efficacious. And as far as I know, there's also drugs that are being developed that have these characteristics. No, I think this is a very interesting data. And there's also a study that is testing now chemotherapy plus minus amivantamab in the first-line setting of exon 20 insertions. So this, I think, is a very interesting study, and it's kind of a competing study with the MOBO study, which, as far as I know, is on hold because of the futility analysis has to be done, and then it's going to be continued. So we will see how these how the TKIs in the exon 20 insertions will fare. I would like to make one point. I'm probably and for the understanding of poziotinib and mobocertinib, what I understood from the exon 20 insertion is that it's a very small kind of pocket. It's very difficult to fit in drugs in this very small pocket, and that the poziotinib has the problem that the IC50 is lower for wild type than for the mutation. So I mean, by definition, of course, the toxicity is very high. With mobocertinib, this is the only drug that has a better affinity to the insertion mutation than to the wild type, but nevertheless, it still has pretty high affinity to the wild type. So we see a lot of toxicity. So yeah, we have to see which drug approach will come out as the leader. And my prediction would be that in reality, it's probably going to be antibodies.
Thank you. Thank you for this very interesting discussion on this very specific subset of patients, exon 20 insertions. We have these challenges for the identification of patients with the need for using NGS to fully characterize exon 20 and not miss some of those patients. We understand that the standard of care, especially the use of immune checkpoint inhibitors, is associated with limited efficacy, and that we have new options coming through clinical trials right now, but with very promising data with TKIs and probably even more with antibodies. So we will obviously have to follow this story in the next meetings. So thank you for your contribution to this roundtable, and again, thank you for following this discussion.